All right, we're ready when you are, Dr. Eckert.
Okay. Welcome, everyone. My name is Dr. Eckert. I'm the founder of Hormonify, and we appreciate you being here. And our purpose is to educate. In fact, more and more of our time at Hormonify is spent educating not only the public, but also practitioners due to the tremendous amount of misinformation that's out there. And so we hope to qualify all of the things that we do and help you understand how we got to the point where we are and why our program works and why almost all other programs have disabilities and failures because of the lack of basic biochemical processes that the practitioners do not understand. So we did a survey, and I'm going to start with the top questions, which were you guys what you wanted to hear, and that was which delivery method is right for me? And that's a very good question to start with. So when I started this, I established a research facility called the Menopause Institute that studied about 1,000 women over 10 years in various methods of delivery. We studied at that point the pellet, we studied the injection, we studied the pill, we studied the creams, which was the big thing in the 1990s. And we studied them over time, but also tried to evaluate what lab tests are indicated and what are necessary. So all of those things took about 10 to 12 years of research. And what we came up with is the following. First of all, to understand hormone therapy, you have to understand the half-life. The half-life means that when you put a hormone in your body, how long does it last before half of it's gone? And so we found that actually twice a day dosing is ideal for almost all the hormones. So any dosage that is given once a day is already inadequate in terms of maintaining adequate levels for all your mechanism. Now you have to look at the cell level. In the cell level, deep down inside in every single cell in your body, you have to understand that the cell is exposed to the hormones. Half the time it has hormones, half the time it doesn't. And then it's something we call deregulation. It means it downplays its ability to function properly. So what happens with deregulation or downregulation is that you over time lose the ability to get the benefits of the hormones if you don't have a constant level throughout the day and night. So twice a day dosing is by far the most important process. Second thing is that the creams do not absorb on a regular basis. Except for testosterone, the cream absorption is poor, meaning you do not get the adequate levels no matter how much you put on because it doesn't absorb well. For example, progesterone we studied, you get maybe levels of 2 to 4. That's not adequate to give you the benefits of prevention of osteoporosis, prevention of breast cancer, prevention of heart disease, reduction of blood pressure. All these things take a requirement 5 to 10 times higher than that. So, in other words, for people who tell me, well, they're on a progesterone pill at 100 milligrams or 200 milligrams for that matter, the only difference is that it's just spiking up higher while you're sleeping. It doesn't really give you, by 3 o'clock the next afternoon, your levels are almost zero. So it doesn't really matter how much you take. It has to do with how you take it. If you take a pill and you swallow it, it will get digested in the stomach. It will get into the portal vein that goes to the liver. The liver is furtherly going to biochemically alter those medications, whatever they are, but especially hormones, and change their construction. So therefore, you're going to over time, you get maybe 10 to 20% of what you're really taking and actively circulating through the bloodstream. We call that the second pass. The first pass goes right into the liver, and then your first pass is after the liver. When we give hormones, the better way is to give the hormones where you have a first pass. The first pass, for example, is if you do it transdermally, which means skin application, you do get right into the bloodstream, but the levels are too low. But if you put it in your mouth and you absorb it transbuccally, the first time around is extremely efficient, extremely beneficial, and it lasts. Then eventually it gets through the liver and it slowly gets metabolized. And that's why on the vast majority of our patients, we found that the best results are taken if you do it twice a day dosing, even if you cut the dose in half. So, in other words, people are focusing when we have a group. I'm sure a lot of you are on the Facebook group. We have about 28,000 people there now, and I review a lot of the questions. And I'd say half the questions are from people who say, hey, I'm doing this XYZ and I'm not getting better, or I'm doing better for a short period of time, and then I fall back in where I was before. The reason is because the structure of organized medicine is such that they use prescription drugs with fixed dosaging, and that does not apply to our needs as hormone replacement, whether it be male or female. So we try our best to get the principles through to the doctors. and we try to educate them. All they do is constantly change the dosaging, usually once a day, and they don't get the results they need, and patients get frustrated, and they keep on changing, and that is not good for the body. The body has to have an equalization, which means that the amount of hormones in the blood relates to how much hormones are in your cells. Certain cells have receptor sites that respond to the hormones for obvious reasons. So, not every cell has those receptor sites, but almost every cell in your body has the appropriate receptor sites. So, in order for us to get the results, you have to understand the basic principles of biochemistry and physiology. And unfortunately, most doctors who I see prescribing drugs to the people who are having complaints don't know the first thing about it. The second issue is very important, individual dosaging. So if you have a pill with either 100 or 200 milligrams, because that's all that's been approved by the FDA for, let's say, micronized progesterone, which is prometrium, you are going to have one or two dosaging, that's it. In our experience, and we have over 1 million patient months of experience, the vast majority of people are much above 100 and usually below 200. So of all the things that they had to pick on both sides, but 95% of the patients are between those two zones to get the maximum effect, to get the benefit of having the hormones with no side effects or no complications. In Hormonify, we have no complications. Why? Because we specialize the dose, because in a troche form, just like in a cream form, in a troche form, which is twice a day, we can actually give you down to 100th of a milligram of the 4 groups of hormones required for you to have adequate balancing and adequate replacement. Not to confuse you, but most therapy programs who are using a estrogen patch and let's say a pill for progesterone don't even deal with the issues of testosterone and adrenal gland function, which is extremely important in maintaining adequate, even levels and getting maximum results from your hormone replacement therapy. Too many people are spending too much time constantly changing the dosaging because the dosaging is not giving the effects they want. The reason is, like I said, is because they don't understand the basic principles of what the hormones do. The hormones are not there to all of a sudden give you some result and then don't give you the result. Like drugs, for example, you take a Valium, enough Valium, you'll go to sleep or you become drugged. That is basically the effect of a synthetic acting on the brain, producing result. In the bioidentical hormone sphere, what makes it so complicated, difficult to understand, and difficult for most doctors to comprehend is that it has to be a slow introduction by stimulating the receptor sites, getting things going again, especially for women who have not been on therapy for a while. And then the effects become stabilized in about 4 to 6 weeks. So at Hormonify, we've learned that you don't see them in 3, 4 weeks because they're still in the process of assimilating, and you don't wait 3 months. That's what most people do. Somewhere in the middle is where you want to evaluate and then change the dosaging based on what the patient is telling you. Now, why is that so important? The next big group of questions was, when do I get blood work? Well, unfortunately, most doctors and nurse practitioners who are doing this don't know the first thing about it. They're constantly getting blood work. Blood work is is only a moment in time, 1 second. It has nothing to do with 2 hours ago, 4 hours hence. Therefore, you're only getting a blip in time. It's good for a baseline before you're taking hormones because it's important to evaluate for the patient what are they deficient in and how deficient are they and how do they explain their symptoms. At Hormonify, we've identified 26 symptoms. In our experience, people who come to us already on hormones have the same amount of symptoms than new patients who come to us with no hormones. The number is about 10. So consistently, people who come from wherever they come from, whether it be a big corporation that uses AI programs or whether it be an individual practitioner in Arkansas, they have the same amount of symptoms. Why? Because a lot of the symptoms are not even addressed. And if you're not addressing it properly, you still have them. So therefore, the net result on almost all the patients who come to us is no effect on the hormone program they're taking, constantly changing and constantly getting blood work. When someone is constantly getting blood work, I will tell you, whoever you are out there, because a lot of people listening, they do not know what to do. Once you have your hormones on board and the patient is taking them properly, and in the 6, 7 week checkup, we ask them exactly how you're taking it, whether you're taking it correctly. Then we ask for symptoms. We do a symptom review. And almost everyone is better. Some are not totally better. So we make some changes based on the history at that moment in time. And then we see them in 3 months. Why? Because by that time, the blood is already circulating with the hormones. It's already getting incorporated into the cells. It's already going ahead and stimulating the receptor sites, and they're beginning to notice an improvement. Some things, as far as symptomatology goes, takes more than 7 weeks to get better. For example, sex desire, sex drive issues. For example, hair, follicle thickness. So we give them more time for that, but also we try not to bombard them with constantly getting lab work because the lab work is not going to show what we need to know. What we need to know is how is the patient doing? It's similar to, for example, insulin. In the 1940s, a very interesting historical fact, the internal medicine department of all the medical schools refused to accept the fact that diabetics need insulin. They refused. For 5, 7 years, articles were written how it's crazy medicine, just like they did with bioidentical hormone replacement therapy for 30 years. They said it's crazy, it's not necessary. And then they started to identify the fact that actually giving insulin lowers blood sugar, and they found that 50% of people in mental hospitals actually were diabetic, and they had diabetic cerebritis and encephalopathy. And they were discharged once their blood sugars were under control. But at the point in time, in the 1940s, early 1950s, insulin was given once a day. Then they said, hey, let's check levels and let's see what's going on. Now went to twice a day. And in the 1990s, it was really standard to give it 4 times a day because the half-life of insulin was being demolished, just like your hormones are being demolished all the time in your body by various organs in your body. Now we give continuous therapy. Same thing with the sex hormone derivatives. Eventually, we're going to put tiny implants in, not pellets, implants that will secrete the hormone on a steady basis. That's going to probably be the opportune way of delivering the hormones. We're not there yet. We have no technology for that because the insulin really is the forerunner of how I see the way we deliver the hormones. It has to be as constant as you can possibly make it, just like insulin, dependent on the time of day as well. So we prefer, after all the studies done, the troche method, which is easily broken in half. So therefore, it's much more economic. It's exactly the 100th of a milligram of every single product in the troche can be administered because of the high-tech nature of the troche today. It's not the same troche of 50 years ago. The troche can put 4 different groups of hormones, and it could be cut in half, cut in quarters. We're getting so good at figuring out what to do. We sometimes use a quarter 4 times a day, just like they did with insulin. These manifestations of our therapy, which no one else does in the country, it's why we're so successful in getting the results we want at much less of a cost without constantly getting blood work, constantly trying to figure out what's going on. We know what's going on. So the method of delivery that we prefer is going to be the troche form. Now, as good, but not as convenient to use, is the vaginal suppository. The vaginal suppository can be cut in half, can be twice a day, but the mucosa of the vagina is very good for absorbing high molecular weight molecules, which is what hormones are. So let's just talk for a second about that. Most people don't understand what micronized means. So if you're taking progesterone pill, it even says it's micronized progesterone. If those of you are taking DHEA, you're going to be taking micronized DHEA. Regular DHEA, if you take it in a capsule form and put it in the stomach, will not absorb at all. You go online, you can pick DHEA. Oh, good. It's not micronized. It's not going to be absorbed. Same thing with progesterone. So we have micronized progesterone. It actually squeezes down the size of the molecule so that it can absorb through the stomach wall. But think, it's so easily absorbed transbuccally. Why are we doing it through the stomach? Because in the pharmaceutical arena, that's how they make their money. They have their patent on the particular dose of a capsule. That's the model. That's about 130 years old, which today is considered old-fashioned. That's not the best method to use for really almost any medication, by the way, is giving it in a capsule form. But that's the pharmaceutical model. That's what we have been brought up with, is that here, take a pill. The bottom line is that troche formations or troche administration of all sorts of drugs has been around literally for 200 years, made from a wax form usually, Now we use a gelatin form, which is a little softer, but it still is manufactured in such a way that it gives you exactly what we want all the time, every day, exactly the same. That's the key to success of the troche. So we move toward the troche form because it's the best. It wasn't at the particular time in the beginning. I didn't really particularly know what the best was. So I had to research it and find out. We do have a program because a lot of people can't afford the troche form. So therefore, we do have a program like everyone else that utilizes a progesterone pill and an estrogen pill. So many patients want that. And we have many patients on that program, which is really the basis of a lot of these companies that advertise millions of dollars worth to get your attention. And what they do is give you an estrogen patch and a progesterone pill. That's it. That's been around forever. There's nothing new, nothing special. And in fact, now the patch is being overused, the manufacturing difficulties in having the actual patch supplied. So that being said, that kind of manifestation is not only incomplete, but it also is extremely irregular. When we studied people on the estrogen patch, the amount of absorption of estrogen varied from 0 to 1,000. So the irregularity of the patch or the nature of the skin also created such a variance that we could not predict the levels we would get. Interestingly enough, when I first started in the 1990s, Premarin was a big deal. Premarin stands for pregnant mare urine. Mare is a female recently delivered horse, and they collected the urine, strung it down, and formulated Premarin, which was given to women for estrogen replacement. Because at that point in time, the 1970s and 80s, the medical establishment believed that estrogen was the hormone of menopause, which today we know is not. So they used to use that Premarin formulation. And when I first started, I checked every woman on Premarin because that's what was used. I used it. When I came out of residency, that's what I used for women who were having hot flashes and night sweats. I didn't know about what the differences were. I didn't study it yet. Nobody knew. So Premarin was given in a form of 0.625 or 1.25, and it was a tablet, and they used to take it. I studied probably 500 patients, and some had zero estrogen in their blood. Some had thousands, especially estrone, which is the bad estrogen, if you want to call it that, and had levels of thousands. So when I read that there was a 26% increased chance of breast cancer with unopposed estrogen, meaning Premarin, I had to extract the ones that did not have any estrogen in it because the production of the hormone themselves in the pill called Premarin was defective. There was nothing in there. The same thing is happening today, by the way, with some of these over-the-counter GLP products and also the proteins that we're seeing, the peptides that we actually have seen the FDA come out with studies to show some of them have nothing in it, the black market. So it's all happening again. But this was a company called Erst, and this company was producing Premarin for years. Basically, complete scam. So when I started doing this, I started researching all the things that were available, especially, believe it or not, the pellet was available. And the Scoto was called Scolo Pellet, and then there was another one that's the precursor to pellet that we see today. They all went out of business because people had such severe complications, they were suing left and right, and the company was gone, and then it was taken back, taken private, and then taken put out again. And with a lot of marketing and advertising and making the physician make a lot of money, it became in vogue, I'd say about 15 years ago. And now it's becoming much less common. The reason is because the severe complications, irreversible damage that occurs with using the pellet has now become pretty well known and pretty well understood. So doctors were making $400 a shot for a year. That's 1,600, and the complication rate was very high, but the doctors were still recommending it because it was a financial gain for them. So women, I can't tell you how many we have that have been on the pellet. They've had some problems. Some of them have permanent problems. Some of them have temporary problems. If the questions were going to be later, if you'd like more of the details, I can give you some case studies about how we just really have turned against the pellet as a form of therapy in any case. I used to call it a death by 1,000 cuts because you have to literally 4 times a year make a cut in your buttocks area. Let's say 10 years therapy. That's nothing compared to what we have patients on. That's 40 cuts. Think about that. That's crazy. All right. But it's still being utilized because they're going to the gynecologist who say, here, this is great. It's going to make you feel good, which it does for a while. Well, so does heroin. but it doesn't mean that's a good long-term therapy to replace hormones properly. Okay. So we covered the second most popular question request was, should blood work be checked after starting HRT? I would say in our hands at Hormonify, I would say 5% of the time we do check levels. Sometimes it's very confusing. Rarely patients are not taking it the way they're supposed to, and it doesn't make sense. They're not better. We figured out what's going on. Let's check the levels. And sometimes we find out that they admit, well, I'm really not taking it the way I'm supposed to. Also, some people just don't absorb. Very few, they don't absorb for whatever reason. They swallow everything. They have a lot of saliva, and so they just swallow it. And again, it goes through the stomach. At that point, some gets absorbed, but like we talked about, not very well. So we check those levels to see maybe the troche is not really meant for them. It's not going to be good for them. And we try to adjust the dosaging. Sometimes when we have patients who have really, they're 80 years old, they're coming to us for osteoporosis, which by the way, estrogen, progesterone, testosterone, adrenal gland function cures 100% osteoporosis. We have zero fractures, zero over 35 years. So we have a patient 85 years old with osteoporosis. Sometimes they have some senile dementia and really don't know if they're taking it. And we want to make sure they're taking it, so we'll get blood levels. But I would say that's 5% of the time, except for the initial assessment, do we even get blood levels to begin with. And then you have to be careful on how to read them. The vast majority of physicians do not know how to read the results. They don't know how to take them. They don't know when to take them in relationship to when the dosages are giving, like we talked about, even with twice-a-day dosaging. If you take it right away, you get something called peak levels. Well, peak levels are worthless because it can go way, 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 way up, and then it comes way, way, way down. You want to really get a median level on the way down, usually halfway, to give you a sense of the average. And that usually has to be X amount of hours from the last dose. Doctors don't even know that. They'll tell people, take it in the morning, whatever you're taking, at 10 o'clock or 11 o'clock, go to SmithKline and get your blood work done. Totally inadequate. It doesn't tell you anything except maybe the adrenal gland. So we really discourage people from going to family doctors who don't even know the first thing about what they do. They waste their time. We have people coming in, and when did you take the hormones? Well, I took it 2 hours before I got the blood work done. Well, it doesn't help us. It doesn't help you. We try to figure out what to do without having to repeat the blood work. So when you are confused about the blood work, it's because most likely the practitioner doesn't even know when to get it. Now we're talking about reading the test. So if you look down on the columns, any moron can look and say, oh, these are within normal limits. And that's what doctors do. Well, normal limits for who? A menopausal woman. Well, if you don't want to be a normal menopausal woman, you want to be a woman who is 38 to 40 years old with hormone stability and not having the 20 symptoms that you're having. So the doctors say, oh, you're normal. Goodbye. Take care. They're not even understanding that the sense of normality is not what you want when you have no hormones. So patients are frustrated. Now I've developed, so a lot of you know my conceptualization of this, and I call it PTSD medical. I must get one patient a day who's absolutely crazy because she's been told 6 different things that were all not true because they begin to research, they begin to find out, and they come to me and they're off the wall. I mean, they're so anxious and they're so inquisitive, which is good, but they're also just so confused. And you have to just sit down and just try to give them a little time to just acquiesce because they're so wrapped up in the BS that they receive for sometimes 5 years from 5 different practitioners. So you have to understand it's a very highly specialized area, which is why we have these Q&As and we have these periods where we can just educate you. And then you take this education and then you give it to your friends, you give it to your neighbors, you give it to your doctor. Or we have many doctors calling, say, hey, I understand you're doing this new therapy. What is it? I said, it's not new. And I've been doing this now for 35 years, but this is what it is. And this is what a basis is. And this is the principles that we adhere to. And we've had no problems whatsoever. So that's the key, I think, to helping your doctor, if indeed your doctor is one of those that really doesn't know anything. Now, most doctors, unfortunately, have a very high self worth of themselves, and they have an ego problem. And so they're not going to admit they don't know anything. So those are the ones who usually do not call me because they know everything. It's like your teenager child, and those of you who relate to that, and they know everything. They know everything better. Okay, so another question was, does HRT cause weight gain? Now, let's break down weight gain into 3 categories. There's muscle, there's bone, and there's fat. So I will say, as a general answer, You will gain muscle and bone, and you will lose fat. Net, you might gain a few pounds, might lose a few pounds, but this is not a weight loss program. I know it's advertised out there by some of these scam companies that if you do your hormones, it's gonna lose X amount of pounds. Completely non-scientific. It's not necessarily proven that because you balance your sex hormones and you help your adrenal gland reduce the effects of cortisol, that you're going to lose weight. That's not necessarily true. Yes, you might, but you also might not. So therefore, we don't promise that in the beginning, especially today when GLP-1s are around and semaglutides are around and peptides are around. We have a lot of things that we can utilize. But in the initial visits and the first few times, we try to use weight as just one symptom of many, many symptoms so that it's not obsessed over, because we understand that people now are very obsessed with weight, especially with the GLP-1 craze that's going on today. We try not to get too fattish. So weight gain issue, even though it's very important and we understand that, is really not the primary focus. So if you have someone who has, let's say, osteopenia, by the way, people don't even know what osteopenia is. A lot of doctors don't even know. Excuse me. So osteopenia and osteoporosis. So what are they? Well, the 1996, the World Health Organization had to establish the guidelines for therapy surrounding osteoporosis internationally. And they determined by certain relative values what your bone density should be and compare that to women of your own age. And so if you have a variations, a T-score, that's greater than 2.5 deviations to the negative, they said that's osteoporosis. Between minus 2.5 and minus 1 is osteopenia, and then normal is above that. So what they tried to do is say that osteopenia is not necessarily need to be treated. It does not increase the risk of fracture. It just needs to be observed. And osteoporosis is definitely an increased risk of fracture, and it should be treated. The pharmaceutical industry started putting out these drugs that made bone scans look better but didn't reduce fracture rate, and they started treating people with osteopenia, which is exactly the reason why the whole system was set up to not treat the patient with osteopenia. So what causes bone loss in this particular age group? Men and women, by the way, the same. Well, after our research in this area, we found vitamin D is essential, calcium is not. Exercise does nothing to increase bone density. And the most important thing is proper hormone replacement therapy. That includes all four groups. So estrogen is probably number one in this arena. I'm not sure progesterone is number one, but they both necessarily have to be given at dosages that are substantial throughout the day and night, referring back to the fact that once a day dosing usually is not enough. Now, the next thing is testosterone. Testosterone is extremely important in maintaining proper bone and muscle health. So if you have a woman who has osteopenia, which a lot of you do have, and it's not a serious problem at all, by the way, it's not going to reduce your lifespan. That means that you have probably a 3 to 5% bone reduction by weight. So if you weigh 120 pounds and 80 pounds is muscle and bone, which is true, you're going to gain, if you go back to normal, about 4 or 5 pounds right there. Now, hopefully you're going to be losing fat, so overall your weight might look the same, but it definitely changed the configuration. So if you're someone who has osteoporosis, we have patients who literally gain 10 pounds, but it's great poundage because it's increasing your bone density and increasing your muscle mass, especially people in their 60s and 70s who lose muscle. I will tell you that's a major problem for women that age, men too, but also women. Okay, they look different, they feel different, they lose their strength. That's one of the reasons why testosterone is so important. Today, unfortunately, because of the basis of the programs out there with a estrogen patch and a progesterone pill, they add testosterone injections. Now, testosterone injections is around from the 1960s. Okay, that's when Olympic people used to go ahead and inject themselves with testosterone. Now, we don't use testosterone injection, period. I mean, maybe once in a blue moon. We just don't have the need for it, number one. Number two, it's a crazy way for women because you'll peak very, very high and then you'll come way, way down. And we talked about that. That's not what we want. For men, it seems to be what even if you peak and trough, men stay pretty much stable throughout the week. But a woman is much more sensitive to the dosaging because they really don't require that much. So the peak and trough gets accentuated. We find that most women know exactly how they feel afterwards, and then they come crashing down before the next injection. So we use, again, the troche method. Believe it or not, testosterone cream, if it's used twice a day, is a very effective way of getting testosterone into your body. But why spend the money? Put it in the troche form, it's easy. So we definitely do not recommend pellet therapy for women. Testosterone levels we have seen are so high, even high for men. So therefore, we do not want to masculinize our female population more than we have to. So therefore, all the therapy that is given through pellet therapy, in my view, and in view of all the science behind it, is that it is actually contraindicated in women to receive high dose of testosterone. Now, we've had patients coming in, I mean, all the time, who've been on the pellet therapy. Most of them are very, very miserable and unhappy because they didn't realize that it was the testosterone because the practitioners were telling them it's not the testosterone. They started putting them on antidepressants, started putting them on all sorts of drugs. The reality is that the pellet therapy puts a lot of women in male levels of testosterone. Now, unless you want to transition to a male, then you don't put a woman into male levels of hormones. I know that sounds so outrageous that when, I tell patients that, why will you be, I see the blood level, it's male levels. Oh, the doctor said it's fine. I mean, I don't understand what that means. The doctor says it's fine. So I think that covers weight gain issue. By the way, at Hormonify, we have what's called a tier system where we evaluate what's fundamental first, and like building a house, we go the first floor, the second floor, the third floor. So just to review, a lot of the patients who already know what I do and how I've established the protocols, for you to understand that, like building a house, let's say the ground floor. What's the ground floor? The ground floor is not GLP-1s. Okay, your family doctor says, oh, the first thing I'm going to do is give you weight loss. You're going to lose weight and everything's going to be fine. That's totally crazy. First floor is nutrition. We get a nutritional assessment, omegas, antioxidants, minerals, generally, sometimes do B vitamins, and therefore we replace what's needed. That's the ground floor. Your cells need the nutritional status evaluated. We have laboratory testing now. You don't have to just go to a health food store and speak to a high school graduate and say, oh, I feel this symptom. I feel low energy. Oh, yeah, take this, take this, take this. No, that's complete nonsense. So first floor nutrition, then sex hormones, progesterone, estrogen, testosterone. Next level after that, adrenal gland. Extremely important. Much more important than thyroid. Everyone talks about thyroid. The family doctor gets thyroid every 3 months, endocrinologist every 6 weeks. It's crazy. 98% of the time, the thyroid is fine. They put treatments of thyroid medicine into their hormone program, and it's totally not indicated. It's the adrenal gland. And the adrenal gland is not being tested because there's no pharmaceutical drug they give for adrenal replacement. Basically, that's the corruption. Excuse me. That's the corruption of the system. Since there's no drug to give, don't even test it. We have been testing adrenal gland function for 30 years. And I'd say 50% of the people are severely deficient in adrenal gland function as it relates to the cortisol production or hypercortisol production in our stressful environment that depletes the adrenal gland. So very important to look at. It's extremely important to know how to evaluate it. That is a good test to do. Usually I like it done every year, especially if it's low. But I know now how much to give to get the results that we need. We do use a special feminizing, a keto, 7-keto DHEA in our practice, as opposed to giving high dose of straight DHEA to females, because again, it has a androgenetic effect that will masculinize a woman and give her certain symptoms that are unpleasant. So that's a little fine tuning, but definitely worth noting. For men, we use straight micronized DHEA, no problem. So next question is, am I a candidate for HRT? Well, first of all, those of you who know and have heard my lectures before, I don't believe in this false delineation of perimenopause and menopause. It's nonsense. No such thing. No such line. You're not perimenopause when you have still periods, and then you're menopausal when you don't have your periods for a year. That's from the 1850s when they couldn't examine a woman. There was no lab work. And they just asked the question, you having periods? No, for a year. You go to the midwife and they'll give you some concoction that they will make to help you with your hormones. The reality is that in the real world, it's a continuum. I've had patients who are 28 years old who have complete ovarian failure. I've had women 52 years old producing progesterone ovulating every month. That doesn't mean they're impregnable, doesn't mean that the egg they produce is a viable egg for pregnancy. But the corpus luteum, which produces progesterone, I measure it and they're getting periods. And they just went to the doctor who said, "Oh, you may have cancer. We have to do surgery." And I check their levels and I do an ultrasound to make sure. And sure enough, they're just producing progesterone like they were when they were 38. That's rare, but we see it, and therefore we don't do surgery. We tell them this is what's going on, and they don't need hormones for usually for a while, sometimes till 55. But I've had so many patients who were mistreated, misdiagnosed, who are 28 to 38, who really are having premature ovarian failure. One of the factors involved in that segment of population is something called polycystic ovarian disease, which really does not produce progesterone for years. And nobody treats it except they give them what they give them. They don't give them what they need as far as replacement. They give them birth control pills, which is high dose, usually ethinyl estradiol, high dose birth control pills, unopposed estrogen, increasing breast cancer, et cetera, et cetera. So, one second. So now we digress, but let me just try to say that the delineation between hormone therapy needed and hormone therapy not needed has to be done by a complete history, someone who's experienced in this arena, laboratory confirmation and/or ultrasound to help you make the final diagnosis so you're properly treating the patient with the proper therapy. So it's not just a simple matter of, oh, I'm perimenopause, like one company says, therefore you take this therapy. I'm menopause. Oh, I'm sorry, we can't treat menopause because we lost our Medicare license. So I think that's pretty much the way it is. Okay. So who is not a candidate for hormone replacement therapy? My mother had breast cancer. My doctor told me I can't take hormones. Absolutely not true. First of all, you're not your mother. Second of all, the exposure to hormones that your mother had, usually birth control pills unopposed or Premarin, may have increased her risk of breast cancer. Environmental pollutants, issues like that come into play. So in my hands, we don't see a family history of breast cancer as a risk factor. Actually, the studies show that even if your mother had breast cancer, it doesn't necessarily mean you're going to get breast cancer at a higher risk. That's a myth. It's not been proven. It's the area you grew up in, the risk of being exposed to certain chemicals in the environment that gets everyone in that area exposed, not only just your mother and daughter, also the neighbors, also relatives that live close by. I'm fighting this cough and I apologize, but I'll try to get through this. So in other words, what other people should not be taking? I have patients who come in and they've had breast cancer. They've been told that they can never take hormones. Now, first of all, that has been disproven by the FDA, reversing their judgment because of a full studying that was done to prevent women for the 40 years, 50 years, to taking hormone therapy if they had breast cancer. There's no correlation, receptor site or no receptor site positive. The reality is that if you give proper balancing hormones at the proper levels, you will not increase your risk of recurrence. We have zero recurrence in our patients with breast cancer. Zero. Can't do better than that. So oncologists, especially breast specialists, make money on breast cancer. They do not make money on breast cancer prevention. Just put that in the back of your mind. Also, they use fear tactics. You may get breast cancer. Always look at the research. The research, for example, for patients who have grade 1, stage 1 breast cancer, the therapy that they use is usually lumpectomy. They'll try to sell you on radiation, which has not been changing the outcome. And your results, 5-year survival is 99.9%, just with lumpectomy. So in other words, you should be surveilled properly, but it doesn't mean you can't take hormones if you're suffering, especially if you can't sleep. Studies have shown over and over again that those who have any kind of breast cancer or any kind of cancer whatsoever who don't sleep do worse. Sleep actually helps your immune system work better and makes you healthy. You know how you are when you don't sleep. You're not the same person. You can't be as efficient. Your immune system is affected. Also, what drugs you're taking. The immune system is affected by a lot of different things, including vaccinations. Now, 5 years after COVID vaccination thing, we now see how taking a vaccination can really severely hurt your immune system response. And we're seeing a rise in autoimmune disease in patients who've had the vaccination versus those who didn't. We're also seeing a rise of serious cancers secondary to the spike protein that is visualized on the COVID vaccination molecules. So we all should put everything in perspective when it has to do with the fear of hormones, because a woman has been on hormones their whole life. So if it's true that X hormone will cause a cancer, why doesn't every person get a cancer? So therefore, that's the key philosophical argument, that it just doesn't make any sense to say that you're giving the exact hormones, exact molecules, the same, sorry, same ratio, and it will cause cancer in 2% of the patients. No, that's the immune system not picking up the anaplastic cells inside your body before it becomes a cancer. That's really what the theory is, which is why immunotherapy is really the key to future therapy for all these cancers, is to enhance your body's ability to fight the cancer when it's even before cancer, just when it's just from cells. All right, so the question here on the survey was, what is the difference between HRT and bioidentical HRT? Well, I used to use the concept of natural HRT years ago when I first started. And then I decided that that wasn't really relevant, because natural does not mean good. I mean, cyanide and arsenic and strychnine are all natural elements, but doesn't necessarily make it good. So natural really is not the key. Bioidentical, like, makes some sense in that really all HRT should be bioidentical. There shouldn't be, for example, methyl testosterone used instead of testosterone, as an example. One is synthetic, one is natural. Birth control pills is an estrogen, ethinyl estradiol. It's not estradiol. Synthetic versus bioidentical. How long can someone safely remain on HRT? They eventually have to stop. I use the diabetic scenario. How long does a diabetic need to take insulin? Well, the more they take insulin on a regular basis, the longer they'll live and the longer they need to take it. I have yet to find a reason to stop a woman on hormones therapy, especially since they feel so well. I can't tell you how many patients stop them by themselves because their family doctor said, don't take them. And they show up 2 years later saying, I have had the worst 2 years of my life. I can't have sexual intercourse with my husband. I don't sleep. I'm anxious. I mean, you name it. There's 26 symptoms. And the family doctor doesn't know anything, but people tend to listen to the doctor as an authority figure. And I'm telling you, in this arena, it's crazy what doctors say to these people. I don't know if they wanted to be sick because then they can see him more often. I'm not sure exactly what's going on there. Okay, a problem we're seeing, especially in the group and in the Facebook group, is that patients want to know, how long does it take for them to feel better? Now, if they're on an inadequate therapy, it may take years. They may never feel better. But adequate therapy, we usually start feeling better almost right away. 3, 4 weeks, you're noticing that you're getting back to yourself, getting back to being, quote, normal. And by 6, 7 weeks, you're pretty good. When we see our patients 6, 7 weeks, I rarely have a patient to say, I say, how you feeling? How's it going? How the hormones treating you? I rarely have a patient say, not well. I will get it once in a while. And we delve into what's going on, why they don't feel well, what are the symptoms that persist, what are the things going on in their life, and we make appropriate changes based on what they tell me. But I would say 95% of the people say, I'm feeling better. I'm not all better, but I'm feeling better. By the 3 month visit after that, all are better, 100%. So I think it takes some time for most people to adjust. Now, I see on these lab tests from other doctors something called sex binding globulin. Now, sex binding globulin is the body produces more of it when you get exposed to exposed to hormones, and it latches onto the hormones, especially testosterone. So people tell me I'm doing great for 3 to 6 months, and all of a sudden now I'm not doing so great. Did you gain weight? Nope, same weight. Any change in your life? No, same stress. So what changed? What changed is that your body's beginning to produce more sex binding globulin that latches onto the hormones and pulls them out of circulation. So we know that happens. So we sometimes have to give a little more dosaging of the hormones to help a woman through this period of time while they're adjusting to this process. Do we measure it? I see these doctors measuring it. No, who cares? I know it's happening. That's the process. It doesn't matter what the absolute number is. So we don't even check it. Okay. We don't care what it is. We know what happens. We just make the appropriate adjustment. A patient asked me the other day, I went to this practitioner and she insists that I take an anti-estrogen. And do I need it? I said, well, what were your estrogen levels? My estrogen levels were zero. Why is she giving you an anti-estrogen? It's called Dimpro. Why are you taking Dim? And I just, I don't know. It was a pellet, progesterone, and DIM. So nobody's measuring estrogen, or they don't even know what it means. She's taking an estrogen, anti-estrogen, even though her estrogen levels are so low, they're almost negligible. See, these are the things that I see, and I just say, I don't know why you're taking it, but you don't need it. We don't have any patients on Dimpro. If you want to go ahead and look at the levels of estrogen that are very high, we try to balance it out with the proper hormones. We sometimes have estrogen dominant people, polycystic ovarian disease, that have symptoms, for example, of endometriosis. We then rarely will use an anti-estrogen to lower their estrogen level while we build up their progesterone and testosterone to properly balance them. Yes, very short-term therapy because we want them to have some estrogen. Estrogen is good, but too much estrogen, not enough progesterone, not so good. Oh, a question that people ask me all the time, what's the risk of endometrial cancer? So the endometrium is the lining inside the uterus. That's where the baby sits, and the lining is called the endometrium. The lining is balanced between hormones, mainly estrogen makes it thicker, progesterone makes it thinner in general. We are able to measure levels on an ultrasound, and 95% of the time, we have between 4 and 6 millimeters. It's amazing how constant it is, which tells us that the hormones are doing great. So what's our risk of uterine cancer? Uterine cancer is from too thickened lining that becomes atypical, then becomes into what's called an endometrial adenocarcinoma, which is a glandular cancer type. That is in our hands, zero. We don't see it because the hormone levels are so properly balanced. It's amazing how the body can do that with giving the right hormone compilation, how it balances out perfectly. So we have no cancer risk. So if someone has a little bleeding, we do an ultrasound, we see may adjust, it may be too thin, but we don't have any cancer. Period. None. Zero. You know how many D's and C's doctors do on patients who have thin lining because they don't know that the thin lining is good? That's what you want. So then my patients go to a gynecologist to have a little bleeding. They see the thin lining. Instead of saying, oh, we need to go ahead and decrease your progesterone, increase your estrogen a little bit, they do a D&C. I'm not kidding. I don't make this stuff up. And of course, it's going to be negative because the basic physiology doesn't change woman to woman. Speaking about breast cancer risk, a study was done at Cornell in 1987 to 1994. And in there, every patient who had breast cancer had their ovaries removed versus those that did not have their ovaries removed, and found that recurrence of breast cancer, this is advanced stage 3, 4, and 5, 3/4. The cancer recurrence rate of high stage cancers was the same. So it's not that the woman's estrogen is causing the problem once you have a breast cancer. It's the unopposed estrogen not having progesterone that really needs the balancing out to prevent a breast cancer recurrence on these women with advanced breast cancer. So they stopped the study, and then since then, ovaries are not removed when someone has breast cancer, by the way. It used to be actually recommended by some people in the 1980s. So that was proven to be completely false. Okay. Ms. Torres, are you there?
I am. There's a couple questions that came in.
Okay, let's how much into it are we? I lose track of time as I enjoy this so much. How much, how long are we into this?
We're about 50 minutes in.
50?
Mm-hmm.
Okay, why don't we, is it okay? Let's take a 5-minute break. People can go and use the restroom, and we'll return in 5 minutes and we'll take some questions from the audience. Does that work?
Sounds great.
Okay, very good.
Guys in 5.
5 minutes. So, how many more minutes do we have? I'm gonna keep the 5 minutes. Was it a lot of material? Was it presented well? Was it received? Okay, Sandra, are you there?
I am.
Okay,
Um,
let's get started with the questions from the audience.
okay. And if for anyone else, if you as you have questions, even if you think he hasn't addressed it yet, feel free to throw those in the chat. The first one we have here is, have you come across women with a high cholesterol levels who is also depleted in testosterone? It's my understanding that these women will not be candidates for the needed hormones. What is your experience?
There's no reason why with a high cholesterol, low testosterone, you're not a candidate for hormones. Again, high cholesterol is a whole nother conversation we can have about the mythology on treating high cholesterol versus the truth behind high cholesterol is, as Atkins said 65 years ago, it's the insulin level. It's the carbohydrate metabolism. It's the exposure to excessive amounts of carbohydrate that actually is the etiology of the elevated cholesterol level that may increase your risk of problems. So, inflammation is just as important. Those two issues together, sugar, inflammation, are the key sources to prevent the deposition of cholesterol. It's not the cholesterol, stupid. It is the actual response of your body to inflammation, usually caused by elevated blood sugars. So the whole approach is pharmaceutical driven with no evidence to support it. Now they say lowering cholesterol is good. However, there's a lot of studies to show it doesn't do anything, and a lot of studies that show it's bad. So in other words, they're going to use the studies they're going to use. It's a good way to continually give you a drug over time, just like psychiatric medication. Good reason to give you something without any evidence to show that it's going to help you. So, low testosterone needs to be treated. Usually, low testosterone is associated with adrenal gland deficiency as well as progesterone deficiency. So, it has to be evaluated like any other patient.
Okay. This question, I don't know if it was sarcastic, but I could feel it. Why in God's name are our medical professionals not trained in hormone therapy for women?
It's not cynical at all. I mean, it is based on the basis of our AMA-based medical school and residency training is on a pharmaceutical model. All other models have been excluded purposely, consciously from the educational system. When I was a senior medical student at Marquette, which is now Medical College of Wisconsin in Milwaukee, I was on the board, the student representative, to work on the issues of the academic profile that we want to have. And I recommended a 2-week course in internal medicine in nutrition. And it got approved by the faculty advisor, and it got approved by the Department of Internal Medicine. And it went up to the governing board and it got rejected They refused to allow, because of certain financial arrangements made, to admit even 2 weeks of nutritional counseling for medical students. 2 weeks to understand the basis of nutrients in the pathophysiology of disease. So to this day, that is the prejudice. You can look back and find the etiology as the establishment of the AMA, the funding by the Rockefeller Foundation. And it's a fascinating read, but I've never joined the AMA because of it.
Okay. Next question is, who invented trochees and what year?
In 1680, 1720 range, trochee was actually a form of delivery, mainly in Germany. There's no name for it, and they made it, like I said, out of a animal wax, and they put medicine in it. So it's been around for quite a long time. There's an article I wrote about the history of it through the European era. It was mainly European format. The nice thing about it was is that it withstood cold and it withstood heat. Okay, unless you get over 150 degrees. So it was able to maintain themselves through a long period of time, especially if you need a medication that you're traveling with. So believe it or not, today, the trochee is put in a little package. You can put it in your purse. You can travel with it. You go in the airport. It's a little, every month supply is just a few ounces. No injections, no tubes of cream. I mean, it's the best thing going for those that have to travel, be on the go, whether for their job or pleasure. So it is definitely, we brought it back and we revolutionized the gel that is in there to enable it to be utilized in such a fashion where it is inexpensive and efficient. So, and it has to be taken 20, 30 minutes to dissolve, because if it dissolves in 5 minutes, you won't get enough of the hormones.
Okay. If four hormones are compounded into one trochee, how will you know which hormone might need to be adjusted or is giving you side effects?
Excellent question. And if I tell you, I have to kill you, because that took me 30 years to figure out which hormone causes what symptoms. I mean, I discuss it with the patient, of course, and the relationship between the hormones, the ratios. So, those of you who remember calculus, it's not just a straight line, it is relationship to the logarithmic value of what's underneath the curve to establish the effects of the hormones. So, it utilizes statistics and analysis to figure out how much hormone over a period of time should someone get to get the proper results. So symptom review in our field, in our office in Hormonify, is 95% of sufficient and establishing which way to go on the hormones. Like I said, if we're getting confusing reports or we're not getting a good report, we will then turn to the inferior model, which is blood testing.
Okay. How often are the trochee formulations adjusted?
Whenever needed. I mean, we have people on the same dose for years, and they're not doing they have no problems. Their bone scan is normal. Their sexual function is perfect. They sleep great. Their mood is good. Their skin is good. Their hair is good. No reason to adjust. If they want to get blood vows to see how it is, sometimes we'll do that just to see it. If they need other blood work, then we'll add it on. But in general, the main function of Hormonify is to be 100%. And that's our goal, and that's what we do. So all people do better, 95% do perfect.
Okay. And what dose of 7-keto DHEA do you recommend?
Well, I experimented a long time ago with 25, 50, and 100, and I found that 100 was the minimum, and either 100 once a day or 100 twice a day seems to be the right level to get the DHEA up and the symptoms resolved. So it usually takes 6 months to a year. So adrenal gland is a chronic problem. Those of you here can read about it. Not much, a doctor is not going to help you very much with it. There's a lot of work done with the effects of the COVID vaccine on the adrenal gland and on how it affected the immune system. So I think that we're seeing more and more information about it. DHEA, dihydroepiandrosterone, is an excellent supplement. It absorbs very well in the stomach as a 7-keto form, not as a straight DHEA form.
Okay. Thank you for everything here. You've provided so much that is otherwise unavailable. I am so grateful. Are trochees covered by insurance?
No, and that's a it's a political issue, not a medical issue. Pharmaceutical companies run insurance companies, and pharmaceutical companies sleep with insurance companies. Insurance commissions work for the insurance industry. There's no reason why it shouldn't be covered because compounding pharmacies are licensed under the same auspices as regular pharmacies. They are under FDA control. Physicians like myself are properly licensed. However, it's only a political issue because pharmaceutical companies still do not want you to receive cheaper, more effective therapies for various long-term replacement value. That's the political nature, and that's it. Really is about the money. Now, peptides, we'll mention that because it's coming up again as an FDA issue. As you all probably imagine, I'm not the biggest fan of the FDA because I understand until recently the FDA is totally corrupt. However, changes are being made, and also in certain areas like peptides, because of the Chinese influence and the contamination of the peptides that are in the gray market or black market, the FDA approval of the peptides, I think, is important. I agree with this aspect of the FDA to control the scamming of patients with products that have not been effective, have not been shown to be effective, are produced in China, come here in the black market with all sorts of contaminants. The FDA is making it very clear that these substances are extremely dangerous and people die from them. And I've read a lot of the reports from the FDA about what's in these products. So FDA approval for peptides, I think, is important. We do use FDA-approved peptides in our practice for specific reasons, but I'm not a fan in general of blanketly saying all these peptides do some good. Some of them absolutely do not do any good. It's a complete waste of money, and some of them are quite expensive. So you have to be careful not to totally disregard the FDA. But in this case, with hormone therapy, it should be covered. There's no reason why it shouldn't be covered. Someone like me should be able to write a prescription. It should be covered. Until there's going to be litigation involved and at one particular time or a politician's going to get involved, it's not going to happen because the financial forces are that behind it are basically saying, if you want to use our drug, even though it may kill you, then we'll cover it. If you want to use a drug that has no complications, no side effects, and will do the job, we're not going to cover it. To me, that's a political issue, not a medical issue.
Okay, and these are from two different people, but they're in the same category. Do we purchase trochees month to month? I'm concerned about affordability. And the next one is, what is the range of cost for the trochees at Hormonify?
The best thing is call the office. I do sometimes if there's a financial issue, I double up the dosage and only take half, like a quarter twice a day instead of half twice a day. So one pack can last you 2 months and it becomes more affordable. It's a little harder to deal with a quarter of a trochee than a half, so we have that mechanism to help. Number two, it's not that expensive. It's around $90 a month. I don't know exactly. You can call the office and you can give them the number and ask for one of the people about the cost of the trochee. However, the prevention, if you figure out what it prevents, the amount of money that you spend, it's about 100 to 1. In other words, you spend $100 on the trochee a month, long term, you're going to be saving 10,000. So in other words, it's really quite a good investment in making sure you prevent a lot of disease, like we mentioned. There's more, of course. But yeah, there unfortunately that there is not a coverage for this at this point. Now, we have this simple start, which is just basically a prescription base that is not as good, but we are having people utilize that so at least they get the proper dosaging and get the expertise. And sometimes we do add testosterone cream to that to make sure it's fine. But again, that's covered, but it's obviously not as good. So, it's a matter of cost.
Okay, and then thank you. Just yesterday, quote, you can get on GLP-1, high cortisol here. This webinar has been life-changing. Thanks to all responsible for this. Oh, we appreciate that comment. And then another one just came in. Did you mention that nutrition is a component of your program?
Yeah, that's the ground level. That's the foundation. I'm not a fan of nutritionists or dietitians. The reason being that their schools were established in 1940s from food companies that were hired by the government to establish guidelines. Anyone who goes to any hospital where there are dietitians knows that you cannot make a worse diet than what you get at a hospital. I used to be fascinated by these diets that they came up with for sick people. And if I would have eaten that, I would have gotten sicker. So people get sicker in hospitals for one of the reasons the food that they get from quote dietitians. Nutritionists are just as bad. They have very little knowledge. They're pushing food groups like this, the seven food groups. So if you invert it, you turn it upside down, you're probably more apt to be truthful and honest about what food needs to be given to people for proper health. And so therefore, I'm not a big fan of nutritionists. As far as nutrition goes, very basic. I mean, all of us like to eat carbs and sugars. Obviously, that's not good for you. And definitely, there's some people who believe 100% protein diets. There are certain people that only eat meat, for example. So I think that's the other extreme. Do I believe in vegetarianism as a food issue, aside from moral issues? Absolutely not. The evidence is clear that vegetarians die younger, are unhealthy, have not as much mental function, both men and women. So the evidence is clear in that view. But if you have a moral issue with eating meat, for example, I can respect that. But as far as that goes, any extreme diets to me are usually something that I would not subscribe to. However, when you are deficient in, for example, CoQ10, we measure CoQ10, we give you CoQ10, you're fixed. This problem is solved. Therefore, we can measure these things now. You don't have to just take something just to take something. Omega is extremely important. I'd say 25% of the people are deficient in omega 3s or 9s. That's one out of four. So again, I think you need to objectify these things and just not just take something because a health food store person says, here, take this. I think that's the old way of doing it. Today we can specify exactly what you're deficient in, replace it based on objective evidence.
Okay. And last question, just to clarify, is it recommended to apply estradiol cream or gel twice a day? What about testosterone cream gel and vaginal progesterone?
Everything twice a day is better than once a day. Let's put it that way. How much you need to take depends on the concentration. Again, creams are a good way to get testosterone, not a good way to get estrogen. Usually, it's not enough. Okay, and the amount you get is usually insignificant. Testosterone absorbs very well, so that's my experience. We do use some testosterone cream if we're giving the simple start. That is the progesterone pill and the estrogen patch. Just a note about the estrogen patch. We use the twice a week dosaging because the bigger patch causes more irritation and skin reaction than the smaller twice a week dose. And we usually recommend the generic so that the pharmacy usually has that in stock. If you use a particular type, like Vivel for example, you're going to usually run out of finding places that have your particular brand. So unlike a lot of companies are associated with certain brands because they get some kind of kickback. We are not. We recommend just writing for generic and whatever the pharmacy has in stock, you'll be able to get because there is a shortage of estrogen patches today. And that's because of production problems.
Okay, I got three more questions that came in. Do you accept outside blood work?
Yes, we evaluate. A lot of times we have values that are obviously off because they're taken 2 hours after the dose. I learned to work through that. When I start a patient on a therapy program, I tell them to continue to take what you're taking when we get our blood work. I'm able to read it through because I don't want you to suffer, for 2 weeks without hormones because hormones do some good. Almost all hormone therapies out there will give you vasomotor stability, which means hot flashes, night sweats, and insomnia will get improved. So I'd like to keep you on it. But in general, we usually prove that your hormone therapy program is wacky. It's not balanced. It's not proper. And so we like to objectify that for you to see as well, so that you can objectify and see the ratios that are way off. Usually progesterone is very low, estrogen is very high, and testosterone, depending if you're on it or not, is usually very low if you're not. If you're taking testosterone injection, it's usually very high. That's what we see. And we also check other things too. We just don't check that. If you're considering growth hormone fatigue and energy issues and considering giving you growth hormone agonist, then we want to check your IGF-1. We check your, if you have metabolic issues, sugar, weight issues, then we check your insulin level. We're not a big fan of hemoglobin 1AC. I think that's overused. That's a general screen, but the true nature of your fasting insulin level is much more direct, in my experience.
Okay. What about estradiol injections?
1990s, 1980s. We
Okay.
don't know. I mean, it's so archaic. Again, it's 1980s. Well, like, so if you want to reminisce and you want to be like the 1980s, I guess it's fine, but it's no reason whatsoever. I mean, if you're going to give estrogen synthetic or estrogen in a non-bioidentical format, use the patch. At least that's a little more advanced. Again, you won't get the levels you need, but the estrogen patch, I'm sorry, the estrogen injection gives you sky high levels of estrone, sometimes 2000. And that is very dangerous for blood clots. So I don't recommend it whatsoever, ever.
Um, can you can you walk us through what else we need to bring once we have an appointment?
Well, most of our appointments are telehealth or a secure video. No, we don't really need you to bring anything except if you when you I usually do a pre-consult, and meaning I want to find out where you're coming from. Those with breast cancer, I'd like to see the biopsy results. I'd like to see the last mammogram or the MRI. If there's a GYN problem like bleeding and fibroids, I'd like to see the last ultrasound. I like to kind of review things up to where I need to be today so that I'm complete. But in general, that's about it. You just need to bring yourself, and most of the patients fill out a like a review of symptoms that it outlines exactly your history. We go over that in detail and try to figure out exactly what your problems are. So I think there's not much you need to bring. If you want to come in person, even if you're not in person, it's really the same thing. Since we don't do vaginal exams, we don't do pap smears on this issue, there's really no reason even to be present uh, unless you want to, you live local. We have patients in every state and 14, 16 countries now. So we're well equipped to handle that.
Okay, two more questions. There are two types of progesterone blood tests. Which is recommended?
I don't know what you mean by two types.
Okay.
If you're talking about this progesterone, which is what you get, and then there is pregnenolone, which people are getting from, that's the 1970s when they used to get saliva testing. That's complete bullshit. It doesn't mean anything. It's a precursor to progesterone, um, and people are getting it. It doesn't help. Okay, it doesn't give you anything. It doesn't tell you anything. There's even people who are taking pregnenolone, and they're taking it orally, and sometimes there's some heavy side effects from that. But no, I would recommend just getting the normal progesterone level. It's that's what it's called. It's in nanograms percent, so in case you're wondering.
Okay. And I'm willing to pay almost anything if I can get a good night of quality sleep. I'm currently waking up 3 to 4 times per night. Approximately how long does it take for the sleep phase to kick in?
Almost right away. Now, I've become a sleep expert because I had to. Um, there are certain things about sleep disorders that we can talk about now. It may not be relevant to you. I'm just speaking in general. So 90% of the patients with sleep disorders that come to us are hormone driven. Fix the hormones, they sleep better. 10% have an underlying PTSD related insomnia that we root out. We try to figure out what it is, and I call it what's left after the therapy is in, and we do the best we can to treat you properly with proper levels of hormones. We refer for psychotherapy if indeed there's certain symptoms associated with waking up, let's say at 3 o'clock. 2:30 to 3:30, that range, if you're taking hormones, means you're peaking out on the hormones, but the subconscious is waking you up because it feels unsafe. I have put a title to that. It's called Lion in the Bedroom Syndrome, LION, because it is coming from prehistoric times when you had to wake up real quick when you hear a twig or you hear an animal in the distance to save your children. So in other words, that protective mechanism is activated. It's a subconscious mechanism. It is very helpful in the jungle, 50,000 years ago, but it can get activated. Those of you who've had children, you know that when your child turns over in its crib, you can wake up. that is a pretty common experience. And it usually shuts itself off when the child is older. Now, sometimes it does not get shut off. Sometimes certain things get activated, like PTSD, post-traumatic stress disorder. And that activation of that mechanism, it's not a disease, it's not negative, will need psychotherapy to find out why it's being activated, but it's there to protect you or you protect your family. So I have to delineate that separate from hormones. And the way I do that is to treat properly and then see what's left and then send for proper therapy. It's 100% curable. It's not a serious problem, yet it can keep someone awake every day, especially if they wake every night, especially if they wake up between 2:30 and 3:30, which seems to be very consistent.
Okay, that's it for the questions on my end here.
Okay, I'm going to mention one more question here, and it's how do you know which provider to trust? I have reviewed a lot of the answered questions in the Hormonify group, and everyone mentions something called the North American Menopause Society and NAMS, and they are funded by and produced by the pharmaceutical industry. And I've read a lot of their material. I disagree with almost everything that they've written. They get certification, and then all of a sudden, these experts go online and they claim themselves to be experts because they're NAM certified. Um, they know nothing. They're still against testosterone replacement for women, believe it or not. That's how crazy they are because it's not a pharmaceutical. Okay, testosterone itself is not a pharmaceutical. So I'm only giving you that generality to not look at certification so much as the experience. It took me about 30 years to figure it out. And what keeps me motivated doing this is educating people like you all to help people through a process because we're now in a transition period. Thank God Hormonify is doing great. We are expanding all over the country. And what we try to do is educate people like you who will then continue the educational process, sending this video to whoever you want to send it to, so that we can go ahead and continue to educate because education and knowledge is going to replace the fear. Now there's fear-driven behavior everywhere with related to hormones. And these doctors are coming in just at the end to figure out how they can make some money. And to me, I'm against that. So there's definitely a moral issue to what I do and why I do it. And I think it's important not to believe anyone, including me. Do your research, figure out what it is that makes sense, and then make a proper clinical decision. Okay, thank you.
All right. Any more questions from the audience? Thank you. We got a thank you from Galina. Make sure I'm not missing anything. But yeah, I think we got all of them.
Okay, very good. Thanks so much.
Thank you everyone for joining.
All right, we'll have one next month, I think, right?
Yes, we will.
Okay. All right, very good. Take care. Bye-bye.
Thank you guys. Bye-bye.